All right, if you're an anesthesia trainee gearing up for exams, you've come to the right place. This is going to be your high-yield masterclass on managing cardiac arrest. We're going to break down everything you need to know, all based on the latest guidelines and evidence, from that initial collapse all the way through to post-resuscitation care.
So let's just start with a single number that really sets the stage for everything we're about to talk about. 7.9%. Just let that sink in for a second. That's the overall survival rate to hospital discharge for someone who has an out-of-hospital cardiac arrest, what we call an OOHCA, here in the UK. It's a pretty sobering statistic, and it really shows you the immense challenge we're up against.
But here's where it gets really, really interesting, and honestly, kind of hopeful. In places where you get a lot of bystander CPR and super fast defibrillation, think airports, casinos, places like that, that survival rate, it just skyrockets. We're talking 40 to 70%. I mean, what a huge gap, right? It shows us that massive improvements aren't just a dream, they're possible. And that's why every single step in this whole process is just so critical.
Okay, so how are we going to tackle all this? Well, here's our game plan. We'll start with the stakes, then we'll look at the core framework, the chain of survival. After that, we'll dive right into the ALS algorithm, cover post-resuscitation care, and wrap up with prognosis and what's next. All right, let's talk about the stakes. Now, you might think things are better in the hospital, and they are, a little. Overall survival for an in-hospital arrest is about 18%. But here's the absolutely crucial point, the thing you have to remember. It all comes down to the rhythm. If you've got a shockable rhythm, your survival rate is almost 50%. But for a non-shockable rhythm, it plummets to just 11%. And that massive difference, it's fundamental. It dictates everything we do next. So, with that in mind, what's our framework? How do we even begin to approach this? Well, the entire global approach to resuscitation is really built around one single powerful idea, the chain of survival. This is our guiding principle. It's everything. And as you can see, it has 4 links, all connected. And you know the old saying, right? A chain is only as strong as its weakest link. It's literally true here. For a patient to have a good outcome, every single one of these links has to be strong, and it all has to happen fast. So let's quickly break down what each link is actually for. First, early recognition and calling for help. This is all about trying to prevent the arrest from even happening. Then, early CPR. This is how we buy precious time, keeping the brain and heart going. Third, early defibrillation. That's what can actually restart the heart. And finally, that last link, post-resuscitation care. This is the crucial step that's all about restoring quality of life. Okay, let's get into the action. When an arrest is actually happening, what do we do? Well, our actions are guided by the Advanced Life Support Algorithm, the ALS algorithm. You can think of it as our playbook. And here it is, the full algorithm from the Resuscitation Council UK. I know it looks like a lot, right? But don't worry. At its heart, it's just a really logical decision-making map. We're going to break down the most important decision points right now. So the very first decision you make is the most critical one. It's a fork in the road. Is the rhythm shockable or not? If you see ventricular fibrillation, VF, or pulseless ventricular tachycardia, that's VT, you defibrillate immediately. But if you've got pulseless electrical activity, PEA, or asystole, your focus switches completely. It's all about high-quality CPR and getting adrenaline in. And that one single branch point, that's what explains that huge difference in survival we saw right at the start. And let's talk about CPR for a second. We always hear push hard and fast with minimal interruptions, but why? Why is that so important? Well, it all comes down to the physiology. Sure, you're directly compressing the heart a bit, but the main thing, the real engine generating blood flow, is the change in pressure inside the chest. And here's the kicker. That pressure drops to basically 0 the instant you stop compressing. Every pause, even for a second, is just devastating for blood flow to the brain and heart. Okay. Let's talk about one of the drugs we use all the time in those non-shockable arrests, adrenaline. I mean, it's been in the guidelines forever, right? But for your exams, just knowing that isn't enough. You have to know the evidence behind it. So, what does the evidence actually say? This is where things get really nuanced, and it's all thanks to the landmark Paramedic 2 trial. So here's what it found. Yes, adrenaline did lead to a small increase in 30-day survival. That's the good news. But, and this is a huge but, it was also linked to a higher number of survivors with severe neurological damage. It's this really complex, difficult trade-off, and it's something you absolutely need to be aware of and be able to discuss for your exams.
Now, while all this is going on, while you're running the algorithm, doing CPR, giving drugs, you have to be a detective at the same time. You've got to be constantly thinking, why did this happen? And trying to fix the underlying problem. The 4 H's and 4 T's, this is our go-to checklist. It's the list of reversible causes that we have to be running through in our heads the entire time.
So, let's say you're successful. You did a pulse back. You achieve what we call ROSC, or return of spontaneous circulation. It feels like a victory, right? But the emergency is far from over. In fact, it's just the beginning of a whole new, really complex phase, post-resuscitation care. This is that final, crucial link in our chain.
And in this area specifically, there has been a huge, practice-changing shift that you absolutely have to know for your exams. For years and years, the standard of care was induced hypothermia. But a huge recent trial, the TTM2 trial, has completely flipped that on its head.
So what does that mean in practice? Well, the whole approach has shifted. We've moved away from actively cooling patients down to 33 degrees Celsius. The new goal is what we call targeted normothermia, which really just means we now focus on aggressively preventing a fever. We actively work to keep the patient's temperature below 37.7 degrees. It sounds like a subtle difference, but in terms of management, it's pretty significant.
Here's another classic question you'll face after getting ROSC. Should we rush this patient to the cath lab for an angiogram? Well, the Tomahawk trial gave us a really clear answer, at least for a specific group of patients. And here's the bottom line. For stable patients who've had an out-of-hospital cardiac arrest, but who do not have what we call a STEMI on their ECG, there is no survival benefit from rushing to an immediate angiogram.
All right, now we're moving into the final, and let's be honest, often the most difficult and challenging phase, trying to figure out a patient's neurologic prognosis after they've survived that initial arrest.
Tragically, after all that work, the leading cause of death for patients who make it to the ICU is neurologic injury. So how do we predict it? Well, the 2021 guidelines are really clear on this. First, you don't rush it. You wait at least 72 hours. And second, you use multiple tools. It's got to be multimodal. A poor outcome is usually predicted by a combination of signs, things like a really low GCS motor score, absent pupillary and corneal reflexes, something called status myoclonus, a really nasty-looking EEG pattern, and of course, clear evidence of extensive injury on a brain scan.
You know, in the end, everything we've talked about, from bystanders doing CPR to the most advanced care in the ICU, it all comes back to this one idea. The goal is always to strengthen every single link in this chain. The work is incredibly difficult, for sure. But as the evidence keeps evolving, so does our chance to improve outcomes for our patients.
And just so you know, everything we've covered here was based on a fantastic 2022 review article called Cardiopulmonary Resuscitation and Post-resuscitation Care, which was published in Anesthesia and Intensive Care Medicine. It's a really great resource if you want to dive deeper. Thanks so much for joining me, and really, the best of luck with your exams.